Good afternoon, everyone, and thank you for the kind introductions. So, as a SEAPID representative, today I would like to share with you the regional priorities on the diagnosis and treatment of primary immunodeficiency. The topic that I would like to share with you today is regarding the genetic diagnosis access issues, and secondly is also about the skin newborn screening. So as may you already aware that the PID management in Southeast Asia is quite limited, both in diagnostic facilities and treatment availabilities. It also issues about the cost reimbursements and insurance constraints. Also in Southeast Asia, there are only a few PID specialists, and rare diseases are not yet the priorities for most of the country. Due to these reasons, so 8 years ago, we come together and established Southeast Asia PID networks, which including 6 founder countries as you see in the pictures. So the SEAPID network have our own missions. Firstly, we would like to promote the educations about PID in the Southeast Asia regions. Secondly, we aim to establish the PID registry of our own, and also the one with APSID. And last but not least, we also would like to find a way to get the early diagnosis for the patients, which also include the aspect of the genetic diagnostic, which should be quite accessible and time appropriate. So the patients who suspected to have PID but without a genetic diagnosis, the treatment that they receive are quite costly, but yet did not get the appropriate disease management and treatments, which finally contribute to prolonged sufferings and decreased quality of life. So what is the challenge for obtaining molecular diagnosis for the patients? Why it is so difficult? First of all, primary immunodeficiency disorder is a diverse group of over 420 genetic disorders that resulted in clinically apparent immune dysfunctions. Secondly, many PID share the overlapping clinical presentations. For example, if you have a child suspected to have severe combined immune deficiency or SCID, you may need to sequence like at least 10 genes to get the right genetic diagnosis. Then for only one gene, for example, RAG mutations, the patient can present it from like a SCID baby, a typical SCID or leaky SCID, Omenn syndrome, or combined immune deficiency. Last but not least, although PID are classically considered as mental disorder with complete penetrance, some disease can present with absence or partial clinical disease. For example, interferon gamma receptor 1 deficiency, SET1 loss of functions, or mutations. Due to these reasons, nowadays, next-generation sequencing like whole exome or whole genome sequencing often be selected as a tool to get the diagnosis for PID patients because it can discover the known variants or the novel variants in known disease genes and also the novel disease-associated genes. But the limitation is always about the unavailabilities and also the cost and inaccessibilities. It's also the problems about the difficulties with interpretations. For the next generation sequencing, you always need to pay the high price. So the price of NGS varies between 500 to 2,000 US dollars, and the turnaround time is around 30 days. But even for this price, the clinical performance is ranged from 15 to 46% with a median rate of 25% from a systematic review of using next generation sequencing in patients suspected with PID. Another choice for PID molecular diagnostic is using targeted PID panels, which these tools you can do the simultaneous examinations of multiple relevant genes with the price of 250 US dollars, and the turnaround time is around 14 days. So the companies that provide this panel is called Invitae, and with these tools you can examine 207 genes that to see if it's relevant to the clinical phenotype of the patients. So let's see what is the clinical performance of these targeted panels. There is a paper that has come out this year. So with the collaborations between Jeffrey Model Foundations and the companies, they offer the free genetic testing for the patients suspected to have PIDs using these targeted panels. And the paper told us that the positive results of molecular diagnosis in the populations is around 20%. Another choice for doing the genetic testing is to use customized PID microarray, which has been generated in collaborations with Erasmus MC, Chulalongkorn University Hospital, IPOPI, and SEAPID network. With this tool, we can detect the known PID variants of 277 PID-related genes. We just finished and published our papers for validate the clinical performance of this microarray, and we found that the clinical performance of this array in our populations is around 40%, and the price is achievable because it's around 40 euro per samples. The turnaround time is around 1 to 2 weeks. We are now not yet currently provided as a service because we are now developed the updated panels from 277 genes to 4,020 genes according to IUIS, the new classifications. So for the first part of my talk, I just finished sharing with you the varieties tools of genetic diagnosis for PID, including next generation sequencing, targeted panels, and our customized array, which hopefully you can select appropriately according to the clinical phenotype of the patients and accessibility of your countries. So now we will move on the second topic about the SCID newborn screening. So for the severe combined immune deficiency or bubble boy syndrome, as you may see in the pictures, they can born with healthy appearing, with no one knows that they have very low or absent T cell productions until they get the first infections. So the Trach assay has been used for a long time ago as a newborn screening for SCID. It is the tool that are using real-time PCR to detect the small circular DNA byproduct that produced during T cell receptor recombinance in naive T cells. So Trach values will be reduced or absent in SCID baby and also other T cell lymphopenia such as complete discharge syndrome or leaky SCID or other kinds of disease with T cell defect, for example, ataxia telangiectasia. Due to the newborn screenings in the US, which has been used for more than 10 years, this leads to a higher than expected incidence of SCID, reaching 1 to 58,000 newborn delivers. And because the child was transplanted quite early, so the success rate is robustly high. So as you may see from the papers in New England Journal, that if the patient's been transplanted before 3.5 months old, the success rate has been reached 94%. So before you can start to consider using Trach as a newborn screening tool in your countries, there are still some issues that you need to be considered. First of all, different cutoff value of Trach has been applied in different populations. For example, in the US, they say that the 25 Trach copies per microliter is a cutoff for calling this child should have SCID baby, while in Taiwan is higher, and in some other countries like in Sweden and Iran is lower. So you may need to find the cutoff points of your countries before can apply the newborn screenings. Secondly, you may need to aware that some of PID which present quite early in life can have or resulted in normal Trach, for example, partially ADS SCID or MSC class 2 deficiency or FOXP3 deficiency, for example. But in Southeast Asia and many countries in this world, the newborn screening program is not yet started. So if anything that we can do without this newborn screening program, because I think in Southeast Asia, at least we are not yet started or even about to start the program. So what I can think and share with you is that the clinicians should be aware of the early manifestations of PID. This is the most important point. They can help you to detect SCID quite early. So you need to also know and also teach your students the clue for the defect of T cell, which including the recurrent infections with opportunistic pathogens, and also if the bacterial infections affect multiple sites, if the infections is quite persist, even they receive adequate conventional treatments, if they have failure to thrive or chronic diarrhea. So CBC is quite one of the most important tools to early detect T cell defects, which we all know that a single findings of lymphopenia is frequently found in like a septic child or common infectious disease. But if the lymphopenia stay for quite a long time and cannot correct rapidly, it should not be ignored and should be investigated further for severe combined immune deficiency. So we are about to start a new project in Thailand together with the technicians all over the countries, that if they come across with a child less than 6 months old who have significant lymphopenia, they should alert the physician in the hospital or even ask the physician to refer the patients to do the further investigations in suspected for having SCID or severe T cell defect. And for other aspect, besides you having this danger signs in your mind, also to have educational activities or raising awareness about PID among general doctors, as we do in the meetings in our Thai Allergy Immunology societies, or if we do together with our SEAPID friends to educate the general doctors, is also helping us a lot for making our young generations to be alert and to be more educated about PID. As we just get the new SCID baby last month, it been referred from our students that just finished from our universities, and they just send the patients to us directly and say this child should be suspected SCID, and this is true. So this help a lot. And also besides the educations among doctors, the public awareness is also important. So the patients organizations provide really great help or in doing the public awareness together with the doctors communities. Last but not least, you cannot work alone for taking care of PID patients. Actually, in your hospital, you need the multidisciplinary team to work or to get the best treatments outcome for the patients suspected to have PID. So within my 20 minutes, I hope that I can share some of the SEAPID perspective with you regarding the genetic diagnosis access issues, and also how we're gonna manage if we're not yet having this SCID newborn screening. So thank you very much for your attention, and all the questions and comments are welcome.